We have a fantastic speaker today that you probably recognize. Carol Crawford is a clinical pharmacist with the Senior Care Clinic, and she is an expert in everything having to do with medications in the elderly. She also does a lot of chronic disease management, and one of those chronic diseases that she manages for our clinic patients very carefully is diabetes. So she couldn't be better suited to give this talk.
Hi. So obviously there's a lot of different things we could discuss regarding diabetes and the elderly, but I thought today I'd focus on glycemic goals. And just kind of for an agenda, was going to review the goals of glycemic treatment in the elderly, the recommended A1C targets for our elderly patients, and then discuss management priorities and treatment choices for an elderly patient, prioritizing specifically hypoglycemia. So I think we all know the benefits of glycemic treatment. There's been many studies in younger patients showing a decreased risk of vascular complications. So better control of sugars now often lead to lower risk of retinopathy, nephropathy years later. So typically kind of like the 10-year period. So patients that are, or older patients with a life expectancy of less than 8 years, for instance, potentially are unlikely to benefit from intensive glycemic control, and potentially also expose them to an increased risk of hypoglycemia. So not optimal. Individualizing goals for glycemic treatment in the elderly, we are not intending to decrease necessarily vascular complications in patients with lower life expectancies, but rather the goal should be to avoid symptomatic hyperglycemia in those patients. So thus, we often will be a little more permissive with our A1C target, usually kind of floating it up to 7.5 to 9, and not typically lower. This is a kind of a busy slide, but it does help us to kind of navigate through how we would decide an A1C goal for our particular patient, with the emphasis on kind of avoiding harm. So the kind of things that we look at and that are kind of emphasized on the patient characteristic health status side, left-hand side of the screen there, we look at life expectancy, obviously, so age of the patient, comorbidity burden, and also the cognitive impairment of patients. And by looking kind of at those three things, we can come up with an A1C goal for our patient. Most of the patients that are in our geriatric clinic, outpatient clinic, kind of run in the less than 8% range. So some comorbidities, some ADLs that are potentially impaired, and some cognitive impairment. So that's kind of where most of the patients that I see at least fall. So A1C goal is good to obviously have, so we have some idea of what we're targeting, but I think it also is important to emphasize that if the goal is hard to achieve, that it may not be worth getting there. So if your next intervention or your intervention leads to substantial or potentially substantial risk, it may outweigh the small additional benefit of tighter control. So as an example, 86-year-old skilled nursing facility patient, A1C is 8.4. Should we start Metformin? Well, probably. Metformin has been shown to reduce, has some mortality benefit, relatively safe as far as a hypoglycemic standpoint, and kind of generally in general. So that would make sense. Similar patient though, 86-year-old resident, skilled nursing facility resident, A1C is 8.4 on metformin and sulfonylurea. Should we start insulin? Well, in that case, maybe not, because the risk of hypoglycemia is not low. Burden of monitoring might outweigh, actually, or likely will outweigh the marginal benefit from improved control. So I think that's another kind of important thing to think about when you're signing an A1C, is just if it's going to be difficult to achieve, then you might consider being a little more permissive. When we're thinking about patients in hypoglycemia, one of the things to make sure that we're aware of is that not only do older patients potentially present differently with symptomatic hypoglycemia, but also they often may have hypoglycemia at a much lower A1C, blood sugar level than, for instance, younger patients. So, which is problematic. Younger patients often will have symptoms at a higher blood sugar level, so that gives us some time to actually kind of correct, whereas our older patients often will present kind of at a critical low blood sugar level, which doesn't give us much time to correct. Along with that is the concept of hypoglycemic unawareness. So patients in our elderly often, especially if they have cognitive impairment, may be one of these patients that have what we call hypoglycemia unawareness, which is very significantly important because it increased the risk of severe hypoglycemia by 25-fold. I mentioned earlier, or just earlier, about hypoglycemia symptoms in the elderly. I think it's important to also remember or note that older adults may have more neuroglycopenic manifestations of hypoglycemia, so may present with, for instance, dizziness, weakness, delirium, or confusion, versus the adrenergic symptoms that we always tell patients to watch out for, like this tremors and sweating. And that's important because obviously dizziness can be, in our elderly patients, there could be a number of reasons for dizziness, not necessarily hypoglycemia, and it isn't always that we, can come to the conclusion of hypoglycemia until potentially it's too late. So strategies for reducing hypoglycemia. We've discussed A1C targets, making sure that makes sense for the particular patient that you're talking about. You want to consider patient capacity, so if the patient can safely do what you're asking them to do. Sometimes we have them, prescribe things that is actually not necessarily unfeasible, but has a high degree of potential for error. Considering treatment burden, so we don't want to negatively impact quality of life by being super restrictive with our patients. And then also considering hypoglycemic potential of prescribed medications is another area to look at. So I think for young or old patients, first-line treatment medication-wise for diabetes is metformin, clearest link with improved long-term outcomes, multimodal mechanism of action. Dangers of hypoglycemia is low, as well as lactic acidosis is low. And so I think we all agree that metformin would be the first thing that you would be placing a patient on, as long as it's appropriate. The FDA not so recently revised its black box warnings for metformin, and why I'm mentioning them here is because I think sometimes metformin is potentially underutilized. Some patients do have problems GI-wise with metformin, but I think sometimes we also are a little bit worried about the GFR cutoff. So just wanted to stress that eGFR really, the medication is contraindicated at 30, but above that, usually metformin can be utilized. My cohort, who is the other pharmacist kind of on this panel that comes when I'm not here, is Zach Markham, and he actually just recently did a study suggesting that metformin could be even initiated at eGFRs of 30 to 45 safely. Okay, so hypoglycemia comparison to diabetic medications. So this is kind of a double-edged sword in a way, because a lot of the medications that actually cause hypoglycemia are also medications that are better at reducing A1C. But if you look, and the SGLT2 inhibitors are not on this forest plot, but generally the good thing about the newer agents, and I say newer even though they've been around for at least 10 years now, is that they are less problematic from a hypoglycemic standpoint. So that's good when we're kind of looking at our newer agents. The other thing to note, and I think we all know how expensive or that the newer agents are, but I put this graph in there because I don't know if people are really aware of just how more expensive these medications are. So even though most of these medicines are now covered on insurances and don't require prior authorization necessarily, if you have a patient that has a copayment percentage for their insurance, they're still, for instance, for a GLP-1 inhibitor, they're still going to be paying a substantial amount of medication, or excuse me, cost or price. and that is often obviously problematic for our elderly patients. So those are kind of the other thing, that is the other thing to kind of think about when you're prescribing diabetic medications for the elderly. So second line choices. So you have a patient on metformin thinking about a second line oral agent. The ADA does not prioritize the next agent that you oral agent that you potentially would add. The AACE does recommend GLP-1 agonists as first line. And both of these, or these two kind of groups of medicines, and granted we could talk a long time about this, so I'm just kind of giving just a general overview, are very different, obviously. Sulfonylureas do have a very long track record. They're cheap and we're very used to using them, and does have some microvascular benefits. Glipizide, as you know, shorter half-life, no active metabolite, is considered the medication or the sulfonylurea of choice for the elderly. But again, some hypoglycemic risk. GLP-1 agonists, patients don't like the injection portion of it. They're very expensive, but they are multimodal in mechanism, which is a nice thing, low hypoglycemic risk. And however, even though that they've been out for a relatively good amount of time now, their side effect profile and their long-term side effect profile is still kind of being ferreted out a little bit. GLP-1 agonists are renally cleared, so it's important to note that. There are two that are not, so Trulicity being one of them, the one I mentioned below, which can be dosed weekly. So if you have a patient who sees a caregiver maybe once a week, even though it's an injection, this might be an option. And it can be used in patients with renal insufficiency. It's a pen, though. It needs to be reconstituted. So patients with cognitive impairment, this might be a problem. So here's kind of generally what we think about when we're thinking about second-line agents. If you were to consider another oral agent for a patient, which is not typically what we do in the elderly, then here are some options that we probably would go to next. And again, we can have a very long discussion about this, and out there you might have some strong opinions about these different medications. What I wanted to kind of point out about them, though, is the DPP-4 inhibitors, so sitagliptin as one of them, SGLT2 inhibitors, so empagliflozin as an example. Very expensive medicine, low hypoglycemic risk, so that's nice, but really minimal A1C reduction. And again, we're still kind of determining what long-term side effects are with these medicines, and so they make me not so excited. It's nice that there is different mechanism of action now in treating diabetes, but they can be not so, they're not going to give you a great bang for your buck. The SGLT2 inhibitors, I wanted to call out just a little more specifically, just because when they first came out, I was really pretty excited about the mechanism of action. I thought this would be great, but they have been shown to, and so for the elderly, not necessarily, unless you're very thoughtfully thinking about your patient prior to prescribing, they can be problematic in our elderly, specifically because they can cause some dehydration, then with subsequent hypotension and hyperkalemia. They've been shown to have increase in UTIs, fractures, and ketoacidosis in patients that are also on insulin. So not to say don't use them, but that is an area for our elderly that, a drug for our elderly that I would be a little more hesitant to use. I put thioglutamines on there, even though they're not a new medication, as one of the options. And I know different attendings have different opinions about their use, but I think there is a potential place in therapy for these medications. Pioglitazone has been extensively tested for cardiovascular sequelae, and it's been shown to be relatively safe. The fracture risk and reports of heart failure development often are at the kind of the higher doses of that medication. So again, with these third-line agents, I call them third-line agents, you just need to be a little more careful about what patient population the patient that you're actually going to prescribe for. And then lastly, just talking about insulin, which we could talk a lot about, dosing, etc. But I did want to make just some kind of high-hoped pertinent points. The first being that we want to make sure that our patients can verbalize hypoglycemia. So if those patients that have hypoglycemia unawareness, we really don't want to be prescribing this type of class of medication. And then some other things, as far as dosing, generally I don't dose based on unit per kilogram per day, but rather just start in a conservative way with looking at units and then titrating up based on their blood sugars. Regular insulin, the second point there, has been kind of pushed aside. It doesn't come in a pen form, so a lot of patients who like pen forms obviously can't use regular insulin. The reason why I'm mentioning it as an option for our elderly patients is because the newer agents, so for instance, Lispro or Aspart, or there's even a newer one that's a little bit shorter acting, for those patients that are getting, for instance, wheeled down to the hall to eat, or if their caregiver has a routine such that they don't necessarily feed the patient, or the patient doesn't eat immediately after being injected, they do have a potential to actually have a hypoglycemic event. Regular insulin onset of action isn't quite as quick. It's about half an hour versus kind of the 10 minutes that some of the other ones are. So that's why I wanted to mention that. The other thing about mixed insulin, so 70-30, great idea in the sense that you're losing one injection per day, which patients do like, but you can obviously tease those out. So the long-acting from the short-acting. So if you have a patient that has variable diets, tends to eat, maybe not like 2 big meals in the morning and at noon and then not later in the day, that sort of thing. So very stable, predictable diets. Mixed insulins may not be the most optimal thing for your patient. And then the other thing I wanted to mention just about insulins in a general way is that there are a number of new insulins out there. So for instance, Degludec, which is what we consider an ultra-long basal insulin. There's some newer ones that are quicker acting, they say. And even the combination NPH with your short-acting, there's other combinations of those. So just to be aware that when you're prescribing that even medications in the same class, they may not be totally interchangeable. And a lot of insurances sometimes will mandate like changes that patients with different names that can be very confusing to patients. So I don't have any kind of like drill down kind of suggestions on that, but I just to be aware that there are a number of different things out there, and very variable. Insulins have very variable costs. So I didn't put that on the slide of costs, just because, for instance, for the older insulins like NPH or regular, you can buy a vial for less than $20. The newer agents, especially if they're a combo, can be up to over $200 and $300 a month. So very variable costs with insulins. And then the last thing I was just going to say about insulin, this is just really a kind of an aside, but because a lot of our patients now use pens, they optimally like those, you'll have to obviously prescribe the needles that go along with it. And when you do, the patients will automatically be getting the 8mm needle that goes on that. You can order a shorter one, which is the 5mm, we call it the mini, and that is actually beneficial for elderly patients that are especially thin, because it does reduce the risk of IM injection, and it also allows them to do a one-handed injection technique rather than pinching and then injecting, which some of our patients have some dexterity issues. So that's just a small point I was going to add on to insulin. So there are a lot of other things I could be saying about medications, hypoglycemia, that sort of thing with our elderly patients. It's hard to kind of fit things into a short time frame. So hopefully this is helpful kind of as an overview, and I'm more than happy to I have charts on different kind of comparable medications that are easy to read, and I use kind of on a daily basis as well.
Great. Yeah, we can maybe include those in our resources that we send out afterward. What questions do you have for Carol?